today's topic will be on pediatric tuberculosis. Okay, and this is from the most recent edition of Indian government, which was launched in 2019-20 National Tuberculosis Elimination Program, replacing our older program RNTCP. So whatever we discussed today will be from the NTEP guidelines 2020. Fine. We'll be discussing about some of the basic aspects of tuberculosis. Okay, and then what is the diagnosis, treatment, adverse effects, and non-adherence to treatment. Other aspects like drug-resistant TB, those are all we'll be covering in our later sessions. Fine. And importance of pediatric tuberculosis is it the same as adult tuberculosis? No, except for the etiological agent as such, most of them is different. So let's see what is the difference between the pediatric tuberculosis and adult tuberculosis, and what are the guidelines in pediatric tuberculosis as per the NTEP program. Coming to the etiology, we'll be dealing with the basic aspects in the starting. It belongs to genus Mycobacteria. Okay, so there are two groups, tuberculosis and non-tuberculosis Mycobacteria. Now, Mycobacterium tuberculosis complex contains Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanum, Mycobacterium microti, and BCG. Of these, the first three organisms mentioned causes clinically significant disease. Now, few of the basic points, microbiological points about the organism as such. It is an obligate anaerobe, and the importance of it being obligate anaerobe is the location. In adult, we'll usually have in the upper lobe cavity lesion. Why? Because they are less perfused areas, and as these organisms are obligate anaerobes, they go and prefer to stay over there. Okay, these are acid-fast bacilli. That is why we use the Zn staining to recognize the organism, and it is due to the mycolic acid content in the cell wall. These are gram-positive bacilli, and they spread by direct inhalation of droplet nuclei. That is why we have not been able to stop the transmission of disease, as it is so rampant in our country, and this direct inhalation by droplet nuclei takes place very easily. Now, coming to the epidemiological aspect, the burden of the disease in our society, in our India. So India accounts to, as a whole, 31% of the total global TB burden. And in children, when it comes to children less than 15 or 14 years, the prevalence of TB is around 3.42 lakh children every year in India get the disease. And the male and female incidence is the same. And though we take it to be 3.42 lakhs, there is one more problem here. The problem is there is a huge detection gap when it comes to children, because of the 100 cases we have, only 56% of the cases get diagnosed, and of that, in 70% of these children will be less than 5 years who go undiagnosed. So 70% of the children less than 5 years go undiagnosed, and under 15-year age group, around 50% of the children go undiagnosed. Why do we have this challenge when it comes to pediatric population as such? Is because most of the clinical presentation overlaps with other conditions. So under 5 years, most of the presenting complaint to our OPD will be a child with fever, a child with cough, a child with weight loss, a child with malnutrition. So all these children come with similar complaints, and it overlaps. So the differential diagnosis as such broadens, and so TB, there are high chances that we might end up missing TB as the diagnosis. And there is no easy point of care diagnostic test, because whatever diagnostic test we have, like gastric what to expectorate the sputum, as it is difficult in children, because the children don't know how to bring out their sputum. So that is our next point, difficulty in getting appropriate specimen. Then the disease as such is possibly when compared to adults, wherein there is a nice cavity lesion. So whatever sputum they put out is from the cavity containing lot of bacteria. That is not the condition in children. So it is the nature of the disease is possibly. So even if we take out the expectorated sputum, we might not end up getting the bacteria. So there is poor yield, and yield improves if there is proper symptom characterization. And one more problem we have is our whole national program as such is mainly concentrating on the adults. So the population, our national program concentrates is on the other half of the population, correct? So the pediatric population might not get all that importance that the adult population is getting. So that is why this whole problem, though we are getting 3.42 lakh children every year, there is a huge detection gap. So if there are 100 cases, the actual cases will be around 200. So we are missing out on other 100 cases. And yeah, next point is 6% of the cases reported to our RHTC are from children under 14 years of age. Okay. Now coming to various forms of tuberculosis. Various forms of tuberculosis are, one, in basic terms, we can divide it to be pulmonary tuberculosis and extrapulmonary tuberculosis, correct? So pulmonary tuberculosis is most common form in children, and the incidence of extrapulmonary, one more reason contributing to difficulty diagnosis is pulmonary TB can be easily diagnosed, correct? But the extrapulmonary TB is difficult to diagnose, and there is more incidence of extrapulmonary TB in children as compared to adults, correct? It forms much larger proportion of cases compared to adults. And anyone can answer which is the most common form of extrapulmonary TB in the chat box? Anyone? Which is the most common form of extrapulmonary TB? Yes, very good. It is the lymph node TB. This is most common form of extrapulmonary tuberculosis in children. Others can be pleural TB, TB meningitis, abdominal TB, bone and joints can be involved, or any other visceral tuberculosis. Fine. Next, coming to the pathogenesis. So this is where we learn mainly what is the difference between pediatric and adult form of tuberculosis. Now, when it comes to the age group, susceptibility of age group as such, our immune system is well capable of not getting the disease even though we are infected, because as we all know, around 80 to 90, around 80% of Indian population, we are already infected with the tuberculosis organism, but we do not face the disease. Why is that so? Because our immune system is good enough to defend. So when can we expect ourselves to get tuberculosis is when our immune system is not functioning properly. So when does this happen in our pediatric age group is initial 5 years of age. So initial 3 to 5 years of age, that is when the system is developing as such. It wouldn't have developed up to its maximum optimal performance. So that is one of the age group in initial 3 to 5 years, wherein there is increased susceptibility to tuberculosis. Next is adolescent age group. The adolescent age group, our body as such goes through a big change. So because of all the hormonal influences and rest of the things, again, and the stress that an adolescent undergoes, again, there might be a dip in his immune system. So that is the next age group that gets affected. So these are the two populations that get affected. But what is the difference between this population and this population is the adolescent age group tend to have disease similar to that in adults. Okay, similar to the cavity lesion in adults. But the pediatric age group, the age group between 3 to 5 years usually end up having the primary progressive disease. So what is primary progressive disease? We'll see. So pulmonary tuberculosis, when it affects invariably most of the, like 80% of the children, 80% of the almost all the children will get infected with pulmonary tuberculosis in their initial 3 to 5 years of age. But how the child responds to that infection, whether the child develops disease or not, depends on his immune system, correct? So in the initial 3 to 5 years of age, the child is previously unexposed, so he is not sensitized to the bacilli, correct? So that is why we call it to be primary tuberculosis. Now, once the bacilli goes into the lungs, there is immune response, correct? So this immune response in the initial 0 to 3 weeks period, what happens is in the initial 0 to 3 weeks, there will be infection of the lung and there will be bacteremia. So there will be bacteremia seeding to multiple sites. But over here, still our immune system or the macrophages have not recognized the bacteria as such. Okay, so there is not much immune response. So the child mostly remains asymptomatic or might have mild flu-like symptoms. After this, what happens is there is activation of the cell-mediated immunity, correct? macrophages looked into that they have identified the organism, they go present it to the T cells. Okay, so it is mainly the cell-mediated immunity that fights against the tuberculosis. So there is development of hypersensitivity reaction. Now, once the immune system finds that there is bacilli, it tries to, if this is the foci of infection, it tries to restrict the foci, correct? It tries to restrict the foci. That is when there is central caseous necrosis with granuloma formation around. So there will be a caseous necrosis, and over here there will be granuloma formation. So what happens is, if the cell-mediated immunity is good enough, then we'll be able to restrict the disease by forming central caseous necrosis and granuloma formation, and it ends up forming primary complex. It ends up forming a healed lesion, correct? If there is malnutrition, or if there is HIV, or if there is any immunodeficiency, the child will progress to have the disease because he will not be able to wall off the disease foci, correct? This is the disease foci. If the immune response is good, you will wall off the disease. But if it doesn't happen, there will be dissemination of the disease, correct? That is when we get the progressive primary tuberculosis. If this undergoes further hematogenous spread, then you might end up with acute presentation like miliary TB or TB meningitis, or later on bones, joints, and other visceral organs might as well get infected. Fine. So this was to do with the primary tuberculosis. Next, we'll see what happens in case of adolescents, what happens in case of the other group, adolescents and adults. Over here, they're already sensitized to the organism, correct? Because they've already been exposed to the bacilli and they've already formed a primary healed lesion. Okay, that time their immune system was good, and they had managed to control the infective foci. But what happens is, in case of altered immune status due to any reason, in that case, what can happen? Few bacilli might remain dormant in the primary lesion, correct? That might get reinfected, reactivated, or the person as such might get reinfected by a primary TB contact, correct? So in that case, there will be reactivation or there will be reinfection, and that will lead to secondary tuberculosis. Now, this secondary tuberculosis, if there is memory, if there is previous memory left from the infection, some amount of memory T cells and B cells are left, then it will end up being progressive secondary tuberculosis, where there will be the adult form of cavitary lesion, correct? That is in case of moderate degree of immune suppression. If there is profound immunosuppression, then what happens is that this will be similar to a new infection again, correct? Because of the profound immune suppression, the body would have forgotten that there has been a previous attack as such. That will lead to, again, similar to progressive primary tuberculosis, or else it will lead to the cavitary form of tuberculosis, that is progressive secondary tuberculosis. So that was the pathogenesis, and that was the difference between a primary and secondary. Now, if we look at this X-ray over here, can you guys identify, if looking at the X-ray, which is primary tuberculosis, which is secondary tuberculosis? This is A, this is B. Yes, good. B is secondary tuberculosis. B is secondary tuberculosis, and A is primary tuberculosis, because in A we have the primary complex, we have the primary lesion, we have the lymph node both forming the primary complex, whereas in B we have the characteristic cavitary lesion. So what is the difference between primary TB and secondary TB? Primary TB age group affected is up to 3 to 5 years and elderly with profound immunodeficiency. Secondary tuberculosis is adolescents and adults. Now these are primary people are unsensitized and secondary tuberculosis is sensitized. Over here, what part of the lung gets affected? Usually it is the right lung, because the airway tends to be straighter on the right side. So whatever bacilli goes, there is more propensity for it to go towards the right side. Secondary tuberculosis, both right as well as left can get affected. Lobe, it is usually mid zone of the lung that is get affected. So either it is the lower part of the upper lobe or the upper part of the lower lobe. That is what is gonna get affected most of the times. As ventilation is maximum over here, the bacilli directly go and lodge themselves over there, and it is characteristically subpleural in location. Again, because the amount of oxygen that reaches subpleural zone is less, and these are obligate anaerobes, so they prefer to form in the subpleural location. Okay. Now over here in the secondary, it is apex of one or both of the lobes due to less oxygen tension and preferential bacterial overgrowth over there. Now coming to the pathogenesis, it is because of failure of host's immune response to contain the primary complex, which leads to progressive primary tuberculosis. But in secondary, it is either because of reactivation of the dormant bacilli or because of reinfection, okay, due to body's poor immune response. Now, lymph node involvement will be more common in primary tuberculosis because once the primary complex is formed, there will be lymphatogenous spread and the parahilar or paratracheal lymph nodes will get affected. But what happens in secondary tuberculosis is lymph node is usually absent. Lymph node involvement is usually absent because once the cavity lesion is formed, around that the immune system manages to form a immune system will manage to wall off the infection, so it will prevent the lymphatogenous spread. Okay, so it is usually absent. Now coming to morphology of the lesion, the subpleural foci of consolidation is called as Gons focus. Then there will be lymphatogenous spread, which will lead to perihilar and paratracheal lymph node involvement, and both together we call it as Gons complex. And over here it will usually be cavitary lesion. So based on this, what will we get on X-ray? Middle lobe consolidation, as we saw, middle lobe consolidation, as we see over here, there is a middle lobe consolidation and perihilar or paratracheal lymph node enlargement. But over here, it is usually upper lobe cavitary lesions. Okay. Now let's come up with a clinical situation. Okay. We have a 3-year-old child. Okay. We have a 15-year-old child. Okay. This 3-year-old child presents to us with the renal mass. Okay. And a 15-year-old child also presents with the renal mass. So in a country like India, our first tendency to diagnose this, if it is something like renal mass, then we will have to consider tuberculosis. But should we consider tuberculosis in a 3-year-old child is the question. Anyone would like to answer? So why not? Why not? Why not is because we'll see. This is called as the Walgren's table of primary tuberculosis. Over here we see that like it gives the timeline of the primary tuberculosis. Okay. Over here we see that in the initial few months, there will be immune conversion and primary complex formation, correct? In the initial few months to years. After this, we can have local lung complication between 5 to 9 years. Then pleural effusion can take place. After that, the miliary involvement and the chronic forms can take place, because we saw over here, once there is progressive primary tuberculosis, then there will be hematogenous spread. This hematogenous spread can lead to acute complication and chronic complication. This chronic complication of bone, joint, and kidney getting involved will take place much later. So what we can infer is the visceral types of tuberculosis like bone, skin, or renal tuberculosis comes at a much later age. Fine. That is what is this timetable telling us. How can a primary TB progress? Fine. Next, we will see what is the clinical presentation. How will be the clinical presentation in a child presenting to us with tuberculosis? So what are the common symptoms we can think of? One is fever for 2 weeks or more. Another one is unremitting cough, again for 2 weeks or more. And then there is no weight gain despite adequate nutrition. Okay. Or there is loss of more than 5% of body weight in the past 3 months. So in the past 3 months, significant body weight loss should be more than 5%. Okay. Then there can be peripheral painless swelling, okay, like lymph nodes. Then there can be meningitis of insidious onset, like subacute meningitis, what we call, like after there is signs of meningitis persisting even after 14 days, okay. Or you can have a gibbous formation, okay, gibbous formation, or any other non-specific symptoms in a child who is been having contact with the infected person. And who are these contacts? Who are these contacts? When does this contact become significant? Can we call them as a contact if they've been in touch with an infectious TB patient 10 years back or something? No, right? So when does this become significant? Can anyone answer? When does this contact become significant? Anyone on YouTube would like to answer? Yes, very good. It is 2 years. 2 years is the significant time that is taken. Okay. 2 years. So these are the common symptoms by which they will present to us. So coming to the definition of symptoms, either it is persistent unexplained fever, which is called as fever persistent for more than 2 weeks and no other etiology can be found out, or persistent cough for more than 2 weeks and again no other etiology can be found out, or there is significant weight loss or failure to thrive. So what is the definition? More than 5% weight loss in the past 3 months, or failure to gain weight in the past 3 months despite adequate nutrition that is being provided and there is no other apparent cause. So if the children, if the one of the child presenting to us is having any of these symptoms, then what do we call them? We call them as a presumptive case. So we call them as a presumptive case of tuberculosis. So once we get the child with presumptive case of tuberculosis, then we go further and do the diagnostic investigations which is required for us to diagnose it as a tuberculosis. Okay. So finally, what is a presumptive case? Presumptive case is a person or child with persistent fever for more than 2 weeks, unremitting cough for more than 2 weeks, and weight loss of 5% or no weight gain in the past 3 months with adequate nutrition, or failure to have nutritional rehabilitation in case of undernutrition babies. Okay, without contact in patient with pulmonary tuberculosis in the past 2 years. Now, as discussed earlier, who are contacts? Exposure to an infectious tuberculosis patient, in a child with the person any form of tuberculosis in the last 2 years. Okay, so this is the definition of contact and we have already learned about it. Fine. Now let's see what is the risk of acquiring tuberculosis. So now a child has come in contact with the person who is suffering from tuberculosis. Okay, infective tuberculosis case. Now, will everyone end up getting the disease? No, as discussed before, not all get the disease. So now what is the risk? If we have a source case and there is exposure to the contacts, okay, 70% of them will not get infected itself. So then there is no question of disease taking place, correct? And other 30% of the cases will get infected. Okay, other 30% of the cases will get infected. And among infected, who will develop disease? Only around 5 to 10% of them will develop disease. So very, very less amount of them will develop primary disease. Rest of them will develop latent infection. Okay, depending on the mycobacterium virulence and host immunity, whichever plays a major role, they'll either end up developing primary disease or latent infection. So lifetime risk of developing disease is just 5 to 10%. But in infancy, it is as high as 50% because the immune system is still not developed, and 25% in 1 to 5 years because the immune system is still developing. Okay. Now, finally, coming to the diagnosis. So now we have a presumptive case of tuberculosis with us. So we have a child presenting with fever for more than 2 weeks, or we have a child presenting with cough for more than 2 weeks, or we have a child who has presented to us with loss of weight of more than 5% in last 3 months, or he is unable to gain in the weight in the past 3 months despite giving adequate nutrition. What do we do? What do we do with them? What is the first investigation that you would like to do in such a case if you are thinking in terms of tuberculosis? Anyone in the chat or on YouTube would like to answer? Good. Okay, chest X-ray. So next we'll see how to diagnose tuberculosis. Now this is a very important algorithm. This can be asked either as your viva or in your exam for 5 marks or 10 marks. Now this is the whole algorithm as such. If I directly teach from this algorithm, it might be confusing. Okay, so we'll deal with it step by step now. Okay, with each of them diagnostic tool that is available to us. Okay, so if we have a presumptive case of TB, first thing we do is chest X-ray. And this is the major change as compared to our previous RNTCP program. Okay, now why so much emphasis has been given to chest X-ray is can be understood by this new pyramid for TB diagnosis. We have the maximum specificity as one end, and we have maximum sensitivity at one end. And radiology is only test which has good specificity. This is the only test which comes in between, correct? It is the only test which has good specificity as well as good sensitivity. That is why so much importance is being given to radiology. But the problem with radiology is we can only suspect that there is tuberculosis, but we cannot confirm, correct? So first step in the diagnosis will be, when we have a presumptive TB case is to do a chest X-ray and see whether it is suggestive of tuberculosis or not. Okay, so do a chest X-ray and see whether it is suggestive of tuberculosis or not. But since we cannot get confirmation with this, next step is to confirm. How do we confirm? That is using microbiological diagnosis. And what is the important of confirmation is they have very good specificity. So once confirmed by microbiological diagnosis, we can tell it for sure that it is a case of tuberculosis. So first step in the diagnosis is to see whether it is suggestive of TB. Second step is microbiological confirmation. And third step is the drug sensitivity testing, which has been made universal under our program. So universal drug sensitivity testing has been indicated because of the rampant prevalence of the rifampicin resistance that is existent. So once we confirm drug sensitivity as well, it becomes a complete diagnosis. So suggestive of TB, microbiological diagnosis of TB, and last step is to complete it with rifampicin sensitivity pattern. Okay. So now the first step is chest X-ray. Okay, so now what are the possibilities that can arise in a chest X-ray? Either we can have a normal chest X-ray or we can have abnormal chest X-ray. Now when it comes to abnormal chest X-ray, again we can have two types. Either we can come up with a situation which is suggestive of tuberculosis, the abnormality which is found, or we can have non-specific shadows. Okay, so now first we'll deal with lesions that are suggestive of tuberculosis. So what are such lesions? One is the primary complex, as we have already seen it before. One, in the subpleural location, we'll have a primary foci of consolidation, and in the hilar and paratracheal region, we can have lymph node. Either it can be a direct evidence of lymphadenopathy in perihilar or paratracheal region, or we can have an indirect evidence by tracheal deviation, or there can be hyperinflation of the particular lobe because of the lymph node compressing that particular bronchi. All these things can be indirect evidence. Okay, and what are the other features? Consolidation with or without cavitation. These are in adult or adolescents, or you can have atelectatic changes, or you can have emphysematous changes, or you can have pleural effusion or miliary pattern. So if any of these lesions are present and there is no other infective or there is no other etiology suggesting, then we'll have to directly go ahead and do a microbiological testing by doing CBNAT, correct? If not, if we have some other non-specific shadows, which is not suggestive of TB, then what do we do is we give a course of antibiotics. And what is important is that do not give an antibiotic that is in the first line or group ABC drugs that belong to tuberculosis, because we might end up with a resistant tuberculosis infection. Okay, so the preferred antibiotic over here is an amoxiclav. So amoxiclav is the preferred antibiotic. Okay, so give a 10 to 14-day course of amoxiclav. Okay, and then we go ahead and repeat chest X-ray. Even in this repeat chest X-ray, there is again non-specific shadows. Then what we do is again we'll go ahead with the microbiological diagnosis. If the shadow is healed, well and fine. If it is not healed, then we'll go ahead and do a microbiological testing again. Okay, so that is how we use chest X-ray. Fine. Now we are done with chest X-ray. We either have a lesion that is suggestive of TB, or we have a non-specific shadow that is not resolved with antibiotic treatment. Next, what do we do? That is when we do molecular diagnosis. Okay, we do molecular diagnosis. What are the tools that are available? What are the molecular diagnostic tools that we have? One is either microbiological evidence. Other one is molecular tests. Sorry, I used the word microbiological evidence before, I think. So it is molecular diagnosis. Okay, it is molecular diagnosis. Now, what are for microbiological diagnosis? What we have one is acid fast bacilli and one more is culture. But the problem with these two is this is not sensitive enough. So this cannot be done every time. And this as well cannot be done every time because the yield of culture is very poor. Second, we have a paucibacillary disease when it comes to pediatric tuberculosis. And third, the duration of time it takes. The present liquid culture as well takes around 2 to 8 weeks of time. So we cannot afford to wait 1.5 months in a patient with tuberculosis because we'll have to start the treatment fast. That is when the molecular tests came into picture. Okay, so what are the molecular tests that is available? One is CBNAT, that is cartridge-based nucleic acid amplification test. And few other newer modalities are coming up like TrueNat, GeneXpert for MTB, and LinePro assay. Okay, so what are the number of samples that is needed? Presently, what are the number of samples that is indicated for diagnosis of tuberculosis? If we have to take a sputum sample, what are the number of samples that is needed? Okay, Shanmuga tells 2. Any other answer? On YouTube, anyone like to contribute? This is again a newer change that has come up. For molecular test, just one sample is needed. Now we don't have 2 samples, one at the time and one more is as an early morning sample. That concept has been removed. Okay, it is just one single sample. So if we are making the child undergo a molecular test, we'll have to collect only one sample. If we are making the child undergo any culture or AFB when indicated, only then we send 2 samples. Okay, so if there is microbiological evidence that is needed, for which indications are different, because usually most of the times we end up sending for direct CBNAT. That is what is given under diagnostic algorithm. So if it is microbiological evidence, it is 2 samples. If it is molecular test, it is just 1 sample that is needed. Okay, now how do we collect sample? Again, when it comes to pediatrics, the child just cannot expectorate the sputum, correct? So what are the hurdles that is present? Child don't expectorate sputum, and second is it is a paucibacillary, so poor yield on smear is present, and culture takes long time to grow. So that is why they came up with gastric aspirate or induced sputum. Use of molecular tests, even though it is paucibacillary, molecular test can pick it up. and use of liquid culture. Now, how do we end up taking the sputum sample? If it is gastric aspirate or gastric lavage, what do we do? If it is a gastric aspirate specimen, we call the patient overnight, and in the night only, once he's had his dinner, we put the NGT tube, we keep him nil per mouth until the next day morning. So, and at around next day morning 6 o'clock, whatever gastric content that is there, we just aspirate it. That is gastric aspirate. If it is gastric lavage, then early morning sample, we put the NGT, then around 5 to 10 cc of NS is put into through the NGT and we aspirate it back. So that is gastric lavage sample. And induced sputum is much more advantage, has many more advantage as compared to gastric aspirate and gastric lavage if the child is able to induce the sputum, because over here fasting is not needed. It can be done in an ambulatory setting, because so anywhere it can be done. You don't need the patient to be admitted. It is less invasive when it as compared to aspirate or lavage, because we don't have to pass in an NGT. Okay, and it can be easily learned by paramedics, because no medical professional is required, no nursing staff or a doctor is required, because there is no question of us putting an NGT. Okay, but the only problem is in induced sputum, the person will be coughing out, so we'll need to have good personal protective measures. Okay, fine. Now, okay, so the same scenario, we have X-ray features suggestive or non-specific shadows but not resolving with antibiotic therapy. Next, what do? Is we make them undergo a microbiological test. We make them undergo molecular diagnosis. Under molecular diagnosis, what is preferred is CBNAT. Okay, so the next step in our diagnosis is make them undergo CBNAT. And where do we make them undergo CBNAT? In an NTEP National Tuberculosis Elimination Program approved CBNAT lab. Okay, so NTEP approved NAT lab, we make them undergo the test. Okay, so CBNAT is a real-time polymerase chain reaction based rapid technique. That is what is CBNAT. Okay, what is the use? What is the advantage of it? It is highly sensitive. Okay, so threshold of around 131 colony forming unit per ml of specimen makes it highly sensitive. So even in case of paucibacillary, as the colony forming requirement is very low, even if it is paucibacillary, it gets picked up. On the other hand, it has very good specificity as well. Around 99.2%, it is MTB specific. It is foolproof. No technical expertise is required, because once we put it into the machine in 2 to 4 hours, it will give us the result. Correct. As there is no exposure to the infectious agent, it is safe for the lab personnel as well. It is a closed system, so no risk of cross-contamination when as compared to cultures. And most important of all is, as the present NTP is recommending universal drug sensitivity testing for all, it gives us about rifampicin resistance as well. Yes, Nikhil Vasudeva, further we will discuss about IGRA as well. What is the role of IGRA? You'll come to know now. Okay, so we make them undergo CBNAT. Okay, next is if it is NAT positive. If it is NAT positive, we have finished with step 1. We have finished with step 2. All we need to do is we need to complete the treatment by confirming whether it is rifampicin sensitive or not. If it is, once we complete the treatment, we get the complete diagnosis. Once we complete it with the drug sensitivity testing, we get complete diagnosis. Okay. Now the situation arrives wherein we have a presumptive case. Okay, we have a presumptive case. His chest X-rays are suggestive. Okay, but CBNAT has come out to be negative. This happens many of the times because, again, because of the paucibacillary nature of the disease, getting a gastric lavage sample itself is difficult because of all of them will not be trained. So because of inappropriate sampling that is used, and the yield of CBNAT itself is poor. It is around 40 to 50%. Okay, so most of the times we will end up with so and so situation. In that case, what do we do? Because the incidence of extrapulmonary tuberculosis is high, we look for and test alternate site like any peripheral enlarged lymph node. Okay, we again try to send a better quality of specimen or any alternate specimen like bronchoalveolar lavage or a lymph node aspirate. And by this time, we'll go and review it at the higher center. Okay, even if this repeat sample which you sent, if it turns out to be positive, well and good. If it turns out to be negative, that is when we take it as a clinically diagnosed tuberculosis and treat them. If there is no other alternative diagnosis, we are not able to look for any other alternative diagnosis, then we think it to be a clinically diagnosed tuberculosis. Okay, so this much sums up more or less the whole diagnostic algorithm. Okay, now let's see a few of the recent advancements in this field. These are newer rapid molecular tests. So what are the two newer molecular tests? One is Expert MTB or RAF Ultra. Okay, so what is this? This is a newer generation nested PCR cartridge. Okay, what is the advantage of this is, we read that for CBNAT, the colony forming unit, that is minimum requirement is 131 per ml. But for Gene Expert, as less as 16 bacilli per ml of sputum will be enough. So the yield is much more as compared to CBNAT. Okay, so it is especially useful for paucibacillary disease. When it comes to paucibacillary disease, it is especially useful. And very soon, this, since it can be used in the same equipment, this Gene Expert is gonna replace CBNAT very soon. So in the coming future, in other 4 to 5 years, we can expect Gene Expert MTB to replace the existing CBNAT. Okay, what is the other one? Other one is the TrueNAT. Okay, so this is a battery operated. Okay, since it is not fully automated, it requires good amount of laboratory personnel training, and it is a 2-step process. Okay, so these are the two new rapid molecular tests that are available, and we can expect Gene Expert to soon come into the picture instead of replacing CBNAT. Okay, now, so we have done with the algorithm. So now in the algorithm, there is not any mention about acid-fast bacilli or culture. So when do we use this? When do we use this acid-fast bacilli, or when do we end up using the culture? Anyone would like to contribute? What is their role in the diagnosis? On YouTube or over here in the chat box? Yes, good. In a resource poor setting. Anyone else would like to answer? So we'll look at the role of acid-fast bacilli. So it is a very cheap and simple method, but the only problem is sensitivity is very less, as discussed earlier. So it can be positive in only 10 to 15% of the children. Okay, there is high level of agreement between observers. Okay, so when do we do this is, like you are in a peripheral setup and there is no CBNAT machine available. So in that case, what do we do? But the patient is sick and you're not able to confirm that it is TB. So one, you will invariably have to send it for CBNAT, but there is a delay involved because you'll have to send it to a higher referral center. The sample needs to be processed there. So invariably that will end up taking around 1 to 2 weeks, correct? So in that situation, we can use acid-fast bacilli. So we take 2 samples for acid-fast bacilli apart from what we take for CBNAT. So the role of acid-fast bacilli is in a resource poor setting, when CBNAT is not available or there is an expected delay for CBNAT, that is when we can use acid-fast bacilli. But the disadvantage is the yield is very poor. Only in 10 to 15% of the children, it turns out to be positive. Okay. And one more limitation is we cannot know the drug sensitivity pattern. Okay. Next, what is the role of cultures? Anyone? What is the role of culture? Role of culture. So, okay, fine. Now, previously, liquid culture was not used, and then the time needed used to be very huge, around 2 to 3 months was needed just to get the bacilli to be cultured, and even then the yield used to be poor. Now it has been replaced by liquid culture all over India. So an NTEP equipped lab, all of them are provided with liquid culture, that is the MGIT, Mycobacterium Growth Indicator Tube. So this is present across all the NTEP lab network, because the advantage of this is it has a short turnaround time. By 2 to 8 weeks, we can expect yield, we can expect the growth to take place. Okay. And what is the role of culture is, we already came across a situation while discussing the algorithm that there is clinically diagnosed TB. You have a person, presumptive case, you have chest X-ray is suggestive of TB, but despite sending CBNet samples, you are still getting negative. So in that case, what do? One is you end up starting it as clinically diagnosed TB, but over there, we are still not able to confirm to our present NTEP guidelines recommends universal drug sensitivity testing, correct? So we are not able to know whether it is sensitive to the rifampicin which we are using or not, correct? So in that condition, we can send it for culture as well. So that is what this sentence tells. Under the current universal drug sensitivity strategy, it is used with specimens like induced sputum, gastric aspirate, or bronchoalveolar lavage if molecular tests are negative but clinically highly suggestive of tuberculosis. Okay, so that is the role of culture. Now, what is clinically diagnosed probable tuberculosis? So when it comes to this, we can discuss it like, one is you have a direct evidence of tuberculosis, okay? So this is a proven case, okay? One more thing is there can be indirect evidence. So what is this indirect evidence? Here is the role of tuberculosis skin sensitivity test, IGRA, and all those things. So what can be the indirect evidence? There are clinical features suggestive of tuberculosis, okay? Or you can have X-ray feature suggestive of tuberculosis, but CBNet is repeatedly negative. Or you have all the clinical features that are suggestive of tuberculosis and there is no other etiology, and you make the child undergo tuberculosis skin sensitivity test and the induration is more than 10 mm. So under all these situations, we might have to consider clinically diagnosing it as TB and name it as probable tuberculosis case and start the treatment, okay? And once before starting the treatment, what we'll have to do is, we'll have to send one sample for culture. That is when the role of culture comes into picture, as we have discussed before. So clinically diagnosed probable tuberculosis. High clinical suspicion of tuberculosis disease based on suggestive symptoms or radiology, okay? And there are other supportive evidence like history of exposure to a TB case, or there is evidence of infection by positive skin test, okay? Rapid microbiological tests are negative and common alternative diagnosis have been ruled out. So whenever there is facilities existing, start the treatment, and before starting the treatment, send for liquid culture, okay? Fine. Now, lastly, as we have discussed everything about the tests that are available, molecular tests that are available, let's look into the limitations of this test. One of the major limitations is the yield which we get is poor. So culture yield in children with tuberculosis is just 45 to 55%, and CBNet yield is as well is similar to this or even less. So only around 40 to 50% of the children we can expect a CBNet positive, correct? So only then we'll be able to confirmatively name the disease as tuberculosis. We'll be able to do it only 40 to 50% of the times. That is one of the limitation, okay? And that is what we see over here as well. If a primary complex undergoes smear testing, only 6% of the time they'll come positive. Culture yield is only 22% of the times, and overall yield is just 23%. In a progressive primary disease, smear positivity is around 18%, culture is around 45%, and overall yield is 47%. Okay. If you have a pleural effusion, then smear yield is even more poor from sputum 5%, culture yield is 28% and overall yield is just 32%. So as a rule, a negative CB-NAT does not rule out tuberculosis, okay, because all these tests have their own limitation. Okay, now as we've discussed, what are the indirect tests that are possible? What are the indirect tests that are possible? To indicate that there is infection, okay, even though we are not able to diagnose, if we need some amount of supportive evidence that the child is having tuberculosis infection, what is the test? Anyone? This is where is the role of tuberculosis skin sensitivity test and IGRA. Okay, so what is tuberculosis skin test? The Mantoux test, which we used to call before, now we call it as skin test for tuberculosis. We call it as skin test for tuberculosis because there are two tests under this. One is the Mantoux and one more is CTB that might come up in the near future. Okay, tuberculosis in skin test, it nothing but tells that there is infection. So what it tests, it tests nothing but the delayed type of hypersensitivity reaction in previously infected people. How do we do? Intradermally, we inject it over the left forearm. Okay, so over the upper 1/3 and the lower 2/3 medial aspect of the left forearm, we give an intradermal injection. How much we give? 2 tuberculosis unit. Okay, given intradermally, and it is read after 48 to 72 hours. Okay, when do we tell it is positive? If the induration is more than 10 mm. Okay, in HIV positive children, if it is more than 5 mm, then we tell it to be positive. Only problem with this is it cannot distinguish from infection or disease. Whichever child, if they're immunized with BCG or they're exposed to tuberculosis and have been infected, they will end up testing positive because they would have had primary complex formation. So there will be delayed type of hypersensitivity reaction, correct? So it cannot differentiate infection from disease. That is one of the drawback. And that is why it just tells us that it is one of the indirect evidence and not the direct evidence. Okay. Specificity and positive predictive value is limited in BCG vaccinated, and it can come positive even in non-tuberculosis mycobacteria also. Okay, fine. And there can be false negative when there is poor immune system, like recently exposed HIV, malnourished children, etc. Okay, fine. So it is just an adjunct to other tests in diagnosis of tuberculosis. And one more help of it is to detect latent tuberculosis infection. It is helpful. Okay, so as part of contact screening or to screen HIV infected children or children on immunosuppressive, if we have to start them on steroids, if CB-NAT report becomes late, then this can be useful. Tuberculosis sensitivity, tuberculin skin test can be helpful. Okay, fine. And this CTB test, it is a newer test that is being recognized by the Indian government, but still it is not come into picture in any of the government labs. But in US and all, it has been recognized. It has been given approval. So this is again one of the recent development. What are the advantages is that it is easy to use, point of care. Okay, it is more specific, so it doesn't come positive even if even if the child is BCG vaccinated, or even if the child is infected with non-tuberculosis mycobacteria, it doesn't turn positive. So it is much more specific as compared to tuberculin skin test. It is based on the ESAT or CFP10 antigens that are specific for MTB. Okay, and it is unaffected by BCG, HIV, or any other atypical mycobacteria. And induration of more than 5 mm is taken positive. Okay, so an induration of more than 5 mm indicates that there is been previous infection. Again, the drawback is it cannot differentiate infection from the disease. Okay, fine. Next is the interferon gamma release SS. Okay, this test also is similar to tuberculin skin test, but over here it is the blood sample that we take. The advantage over tuberculin skin test is, again, this is much more specific because it will not come positive in a BCG vaccinated child and a child with non-tuberculosis mycobacteria. Okay, fine. So it is one of the serological tests that assess latent tuberculosis infection, okay, by detecting interferon gamma generation by the T cells in response to MTB specific antigens. Okay, so it is called as quantiferon gold or ELISpot TB test. Okay. Now it is similar to the tuberculin skin test. It detects only LTBI. Okay. So these antigens are not present in BCG or Mycobacterium avium complex or any non-tuberculosis mycobacteria. Hence, it has increased specificity. Okay, and only single visit is enough. We don't have to call back the patient after 48 to 72 hours because it is a blood test and the result will either show it as to be positive or negative. It can be available within 24 hours. That is one more advantage. Okay. Only drawback is it is costly. Okay. The drawback is one is it is costly and it needs a properly trained personnel because blood samples must be processed within 8 to 30 hours. So if the infrastructure is not that good, if we have to transport the specimen, then we might expect a delay, and in those conditions we will not be able to perform. Okay, errors in collecting and transporting the blood sample as told earlier, and this as well cannot differentiate disease from infection. Okay, fine. And there are limited data available or limited study available in children less than 5 years of age. Fine. So to totally summarize all these diagnostic tests as such, there is direct evidence, indirect evidence. Indirect evidence is from chest radiography and tuberculin skin test. Direct evidence can be from smear, but the problem with smear is yield is poor. Only 10 to 15% of them come positive. Next is culture. We don't routinely send because again, yield is poor. Second is it takes very long time. So the best available method is at present is CBNAT. We can get the result within 2 to 4 hours. Okay, fine. So, and that has to be performed in a NTEP approved lab. Fine. So to summarize whatever we have read till now, before we go into the treatment, one is the disease part, other one is the diagnosis part. So first, basically, we can, a child who gets infected within 5 years, okay, so that is what he forms the Gons complex. So regional lymph node can be involved and Gons focus. If if the child manages to contain the infection, no problem as such. If the disease progress, then we have the progressive primary tuberculosis. So it can either have airway involvement. So that is when we discussed that if there is airway involvement, then we can have atelectasis, emphysema, hyperinflated lungs. All those things are possible because of the lymph node pushing into the airway. Or the Gons focus itself can progress. Then what can the child present with? The child can present with parenchymal consolidation with cavitation, or he can present with pleural effusion, or he can present with miliary tuberculosis, pericardial effusion, etc. Okay, fine. So that is the summary of the disease as such. Now, the summary of diagnosis, what we have learned till now. Firstly, identify the presumptive case. So what is a presumptive case? Fever for more than 2 weeks, cough for more than 2 weeks, or not adequate gain despite adequate nutrition in the past 3 months, or weight loss of more than 5%. In such cases, we make them undergo chest X-ray. Chest X-ray can be normal or abnormal. If the chest X-ray is normal, still is a presumptive case. Evaluate for extrapulmonary tuberculosis. Okay. Referral to a higher center. Okay. For other investigations to be done. If chest X-ray, it can be either suggestive or not suggestive. If it is not suggestive, give a course of antibiotic that does not have action against tuberculosis for 7 to 14 days. Okay, then you repeat chest X-ray. If the repeat chest X-ray shows persistent shadow, then make them undergo CBNAT. Or if chest X-ray is highly suggestive of shadow, make them undergo CBNAT again. What are the samples that can be removed? Gastric aspirate, induced sputum, gastric lavage samples, or an expectorated sputum sample if available. Well and good. So either CBNAT can come positive. If CBNAT is positive, then it is just a confirmed case. To complete the diagnosis, we'll have to do drug sensitivity testing. So go ahead and determine rifampicin resistant or sensitive. If CB-NAT is negative, then we search for extrapulmonary tuberculosis source. So lymph node or anything as such, we search. If possible, look for alternate specimen like ball, if possible, and send a repeat CB-NAT. Okay, if the repeat CB-NAT is positive, well and good. If the repeat CB-NAT is negative, still we are suspecting, then it becomes a clinically diagnosed case of tuberculosis. Okay. And most important part, which we have not told, is every child who tests positive for tuberculosis, please make them undergo HIV testing as well. Fine. Now let's look into the treatment aspect. So now we are done with the disease. We have diagnosed the disease. Now how do we treat? So the basic concept of this chemotherapy is there are the metabolic profile of the organism. Depending on the metabolic profile of the organism, we can divide them into three. Okay, type A is actively dividing organisms. Okay, they are actively dividing. So type A, these organisms have maximum sensitivity to isoniazid. Okay, fine. Type B is the intracellular organism which are slowly multiplying. Those are the organisms which remain dormant. So we'll have to take care of this dormant organism as well, because they might end up being the cause for reinfection later. So for this one, pyrazinamide is much more sensitive. And there is one more group of organism. They are extracellular and slowly multiplying organism. And for this, rifampicin is good. And to take care of all these three metabolically active organisms, that is where the role of multiple drugs that is needed to treat TB. So one is to prevent resistance, two is to take care of all these metabolically active organisms. We'll have to treat them with multiple drugs. That is why is the recommendation for combination therapy for treatment. Okay. So now what are the first line drugs that are available for treatment of tuberculosis? Anyone? First line drugs that are available? Yes, good. It is HRZD. Streptomycin is not the first line drug anymore. It has been removed. Okay, fine. So what is the regimen? And again, there is no category A, category B and all. All those things have been removed. It is just one category patient. Okay. Under them comes the newly microbiologically confirmed pulmonary tuberculosis, newly clinically diagnosed pulmonary tuberculosis, newly microbiologically confirmed extrapulmonary tuberculosis, or newly clinically diagnosed extrapulmonary tuberculosis. And these are the new set of patients that have been included. They are drug sensitive, previously treated tuberculosis. So these previously tuberculosis treatment can be anyone with recurrence, or those who have been lost to follow-up, or those who have faced failure of treatment. All these people, we make them undergo the drug sensitivity pattern. Okay, so for that different algorithm exists wherein we look for drug resistance. Okay, that we'll discuss in a later session. In such conditions, if they are sensitive to rifampicin, then they are included in this algorithm itself. And what is the regimen? It is again a daily regimen. Alternate regimen has been removed. So now we'll have to take drugs need to be given daily. Okay. So an intensive phase consisting of HRZE for 2 months given daily, and a continuation phase consisting of HRE, isoniazid, rifampicin, and ethambutol for 4 months. And in the continuation phase, again, ethambutol has been added. Okay. Fine. So what's new in the treatment of tuberculosis? Because of high prevalence of isoniazid monoresistance, there is addition of ethambutol as well in the continuation phase. Okay. Intermittent regimens, the one which was present before, which was given on alternate day, they have high incidence of resistance. It led to the development of high resistance. So daily treatment is being told. Okay, daily treatment is being recommended now. Next is poor outcome on retreatment regimen, hence the removal of category 2 has been removed. Okay, again, these retreatment cases, once they undergo drug and sensitivity pattern, if they come up rifampicin sensitive, they are included under category A itself. So there has been removal of category 2. And if there is rifampicin resistance, they are managed as multi-drug resistance tuberculosis itself. That we'll end up taking it on a later date. And what are the recommended drug dosages for rifampicin? It is 15 mg per kg per day. Isoniazid, it is 10 mg per kg per day. Pyrazinamide is 35, ethambutol is 20, and streptomycin as well is 20. Okay, but since it is very difficult task when it comes to pediatric, especially to calculate mg per kg per day and give it, what our government has come up with this an easier way, that is fixed drug combination for incorporating this multi-drug therapy. So each pediatric formulation that we get will have all the 3 drugs that is needed with a separate ethambutol. So one pediatric formulation will have 50 mg of isoniazid, 75 mg of rifampicin, 150 mg of pyrazinamide, and 275 mg of ethambutol. HRZ comes as one tablet, ethambutol comes as a separate tablet. So based on different weight bands, if we belongs to 4 to 7 kg, we give one pediatric formulation with one ethambutol. 8 to 11 years, 2 pediatric formulation with 2 ethambutol. 12 to 15, 3. 16 to 24 is 4. 25 to 29 kg, we give 3 plus 1 adult formulation. 30 to 39 kg is 2 plus 2 adult formulation. Okay, more than 40 kg, we treat them as adults itself. Okay, fine. Next important thing is pyridoxine is given for all the children, not like the previous recommendation where it was given only for adults. Pyridoxine is given for all the children at 10 mg dosage until the end of continuation phase. When it comes to drug resistant TB, when we are giving the other higher drugs, then 50 to 100 mg can also be considered. Okay, fine. Next is the role of steroids. Role of steroids. When is steroids given? In case of CNS tuberculosis, steroids are indicated. TB spine with cord compression, steroids are indicated. Miliary TB with alveolo-capillary block. Okay, then TB pericarditis. If there is adrenal involvement, okay, endobronchial TB or laryngeal TB, which leads to airway obstruction. If it is causing vasculitis or aorta arteritis, TB uveitis, and during if TB with HIV co-infection is there and the child ends up with iris, then we give steroids. Okay, and it was previously being recommended for all the pleural effusion or all the intestinal tuberculosis case or all visceral tuberculosis case, correct? That is why the recommendation has been changed. We give it in case of pleural effusion only if there is respiratory compromise. Okay, if it is large bilateral pleural effusion, only then we give, or else for every pleural effusion case, we do not give. If the intestinal tuberculosis is going ahead and causing obstruction or stricture formation, only then we give. Okay, until and unless there is massive ascites, we don't give for any other abdominal TB. Okay, collapse, if there is an endobronchial TB leading to collapse consolidation, only then we give steroids. Okay, and every tubercular lymph node mass unless there is compression. Okay, unless there is compression. If the tuberculosis lymph node mass causes compression, only then we give. Okay, so these are the recommendations. Fine. Next is how do we monitor treatment? How do we monitoring the treatment? Okay, now how do we ask them to come for follow-up? Correct, that is important. Fine. Now we know very well how to treat the child with, we have a child with confirmed or complete diagnosed. We know how to treat the child. We know what are the formulations to give. So we have started him on the formulation. Next is when do we call? Should steroids be started with ATT in case of a child? In case of a child with nephrotic syndrome, to start the child with ATT and steroids, the problem is we'll have to give ATT for 14 days and only then we can start the steroids, because maximum bacterial load that is present gets killed by the initial 14 days of treatment. Okay, so any case of latent tuberculosis infection or a child with positive tuberculosis, the guidelines is to give ATT or to give isoniazid rifampicin combination in a case of latent tuberculosis, wait for 14 days and then start on steroids in the case of nephrotic syndrome. So next is how do we call for monitoring? When do we follow? Okay, the first follow-up is at 2 weeks, okay, to recheck whether the patient is taking the treatment appropriately and whether there is response to therapy. Okay, and then we do it every month. Okay, and after completion of treatment, every 6 months up to 2 years. Okay, every 6 months up to 2 years we do the follow-up. Okay, and at every follow-up, what do we see? We see for appropriateness of therapy, whether the child is responding, whether the child is taking the tablet appropriately or not, and we see for any we see for the clinical response and if there is any deterioration or not. Okay, that is what we follow up for. So what is the expected clinical response? Commonly, most of the patients show defervescence and subsidement in all the symptoms by first 2 to 4 weeks, but a few of them might take longer. Okay, a few of them might take longer as well. Weight gain usually starts by the end of 4 weeks, but 25% of them might not show any significant weight gain even on any treatment. Okay, so any deviation in this, then only in that case we'll have to be suspicious. Okay, so this is how we monitor for responsiveness to therapy. Fine. Next, what is the role of follow-up radiographs and what is the role of repeat CBNet? As we had seen before, at the end of, in our previous guidelines, we used to repeat CBNet at the end of induction phase. We used to repeat chest radiography at the end of CBNet. Whether it is recommended in our present guidelines? It is no. So the role of follow-up radiography is, if there is slow resolution of symptoms or persistent of symptoms even at the end of induction phase, only then we repeat a radiograph. If there is any deterioration at any point of time, then even then we can repeat a radiograph. Okay, so it is not required in any children who are improving except at the end of continuation phase. So a follow-up radiograph is only indicated at the end of the treatment until there is any clinical deterioration or the child is not responding well to treatment even after the induction phase. Next, what is the role of repeat CBNet then? So repeat CBNet is done only at the end of induction phase or at the end of therapy, when only and only when the child remains still symptomatic or if there is any deterioration. Okay, fine. Or if there is any failure to respond. So that is the present guidelines. Next is what we call it as paradoxical response. Okay, what is this? Paradoxical upgrading reactions or paradoxical response. Now, what is the importance of this is there might be certain appearance of new symptoms or there can be sudden deterioration as well. So we should not get carried away thinking that there is a failure to response. Okay, that is why the importance to know what this paradoxical response is. So this refers to enlargement of old lesions or unexpected appearance of new lesions during the adequately taking ATT. Okay, it usually occurs 3 to 12 weeks after beginning of the treatment and most frequently after 6 to 7 weeks of treatment or at least 2 months. Okay, and it is usually self-limiting. It resolves without any serious sequelae. Okay, usually regress without a change in any drug regimen. So no change in treatment regimen is required. Okay, so this, how can they present to us? Either as an increase in the size of mediastinal lymph nodes or area of pulmonary infiltration in pediatric patients with primary TB, or appearance of new lung infiltrates in a treatment in a extrapulmonary TB patient, or development of pleural effusion. Okay, all these things are basically because of immune response of the body. Okay, or increase in the size of pleural effusion or appearance of effusion on the other side. Okay, appearance of new lymph nodes or enlargement of the previous lymph nodes, or increase in the size of tuberculoma or infarctions or hydrocephalus in case of a TB meningitis. Okay, so these are paradoxical upgrading responses. Now, as a whole, to summarize, if we have a child who is not responding well to treatment, so what do we do? So we have seen, what do we think of? First thing we'll have to think of is he is not adhering to the treatment, and that is the cause for non-response of the therapy. Correct? So poor diagnosis, either the diagnosis is wrong or he is not adhering to the treatment. That is what we'll have to think first. Second one is it can either be a superadded infection or on any other comorbidity that the child is suffering, and that is causing the problem. Or one of the causes paradoxical upgrading reactions, which we have seen now. And last, we'll have to think of drug resistance. Okay, fine. Now, what are the adverse effects which we can expect out of the treatment which we give? So they do come up, all these drugs have their own side effects, and we've read this before as well. Like isoniazid can present with skin rash, hepatotoxicity, jaundice, or peripheral neuropathy. Rifampicin, benign thing which we'll have to counsel everyone is discoloration of urine, and other one is hepatotoxicity. Okay, pyrazinamide also can cause hepatotoxicity, joint pain, and hypersensitivity. And important side effect of ethambutol is ocular toxicity. So there can be impairment of vision. Fine. So common side effects that we can expect is hepatotoxicity, skin rash, ocular toxicity, ototoxicity or nephrotoxicity, hypersensitivity reaction, joint pain, and neuropathy. Okay. Now, so since we can expect all these symptoms, how do we monitor? Whenever we call for monitor, how do we monitor for these adverse effects? Okay. So we don't have to make them undergo any routine lab investigation until and unless they are symptomatic. So just clinical monitoring is required. No routine lab investigation is required. Okay. Inquire about all these symptoms at every visit. Okay. And you counsel the caregivers that all these things are possible. Okay. Fine. Now, next, I'll give a clinical scenario wherein a child has been started with ATT. Okay. Has been started with ATT. It's been 2 weeks. So he has come for first follow-up. He has come for first follow-up. Now you see that his symptoms are resolving. Okay, so he is responding well, fine, well and good, nothing to worry. But on examination, you found that the child is icteric. Okay, since the child was icteric, we made him undergo LFT. So his STB was increased. Okay, and AST/ALT was more than 3 times the normal limit. 3 times the normal limit. What is the diagnosis now? What has happened now? Anyone? What has happened? Yeah, side effect, I understand. What is it called? What is this called? What is this entity called? This entity is called as drug-induced liver injury. Drug-induced liver injury. And what is the definition? If it is more than 5 times the upper limit of normal of AST and ALT, if there is no symptoms, rise in ALT or AST more than 3 times with nausea, vomiting, and diarrhea. Okay, or STB above 1.5 milligrams per deciliter. If any of them is there, then we term it as drug-induced liver injury. What are the common symptoms they can present with is nausea, vomiting, anorexia, pain abdomen, jaundice, unexplained fatigue, hepatomegaly, or any bleeding manifestation, with nausea, vomiting, anorexia, and pain abdomen being the most common presentation. Okay, if we encounter a case of drug-induced liver injury, then how do we go about? That is when we'll have to stop the existing ATT. If the child has responded well and if he's stable, then we can stop all the ATT and nothing to be given. But if the child is sick, then we'll have to think about alternate drugs like levofloxacin, streptomycin, ethambutol. Okay, fine. Then what do? We repeat ALT after 7 days. If ALT has reduced less than 2 times the upper normal limit, then we first start with rifampicin. So we will start with each and every drug single-handedly and see which drug was responsible for this disease, and we remove that drug. That is the basic concept over here. So we start rifampicin at full dose. Okay. Again, repeat LFT after 3 days. If it is still less, then we add other drugs like isoniazid. Again, we repeat. Again, we add. So we keep doing this over a period of 3 to 5 days. Okay. If there is resurgence of ALT more than 5 times upper normal limit, then we get to know that that particular drug is responsible for drug-induced liver injury, and we eliminate that drug from the treatment. Okay, so that is the basic concept. Fine. Next is non-adherence to treatment. So this is one of the very common scenario which we will encounter, correct? There will be non-adherence to treatment. So in that case, what we do is, if there has been interruption only up to 4 weeks, if the interruption is less than 4 weeks, okay, so this is the scenario. So 1 is if he's in his induction phase, 2 if he's in his continuation phase. If he's in his induction phase, then what do we do? We just restart the whole regimen, correct? If he's missed it for more than 4 weeks, okay, if he's missed it for more than 4 weeks, and it was during his induction phase, then we restart the whole therapy. Okay, before restarting the therapy, he'll have to undergo drug resistance tuberculosis algorithm to test for universal drug sensitivity pattern, because he might have developed resistance, and we restart the whole treatment. But the same thing, if it has happened in the continuation phase and this thing is less than 4 weeks, in that case, what do? We just continue. Nothing needs to be done. So there has been non-adherence to treatment less than 4 weeks. If he is in continuation phase, don't do anything, just resume his treatment. If it's in the induction phase, then you restart the whole treatment again. But if the interruption is more than 4 weeks, if the interruption has been more than 4 weeks, then reinvestigate for drug-resistant tuberculosis. If rifampicin sensitivity resistance is not detected, then retreat with first-line therapy, and you start the whole treatment as such from the beginning. Okay. If drug-resistant pattern has been found, then treat it as MDR-TB. Okay, that's it, simple. So interruption less than 4 weeks, more than 4 weeks. If less than 4 weeks in the induction phase, just restart the treatment, don't do anything. Okay, no need to make him undergo the drug-resistant tuberculosis pattern. If it is less than 4 weeks and he belongs to continuation phase, then you continue, just resume the therapy, don't do anything. But if the interruption is more than 4 weeks, we'll have to investigate for drug resistance. If it is sensitive to rifampicin, then start the whole treatment again from the beginning. If it is resistant, then treat it as MDR-TB. So yeah, that's it, guys.